welcome to this edition of Digital Rebar, Aptitude's podcast on all things happening in the technology space. My name is John Cooper, and I've been with Aptitude for a little over 5 years and in the industry for over 20 years. I'm the East Region and National Healthcare Operations Director based out of Nashville, Tennessee. And today we're talking with Jeff Goad, the Chief Information Officer here at Williamson Health, located in Franklin, Tennessee. And Jeff, before we get started, first, let me thank you for your time.
Thank you.
And giving us the opportunity to sit down and talk. And, as we've worked together over the past year on your ED renovation and tower expansion, you and I have gotten to know each other pretty well. If you don't mind, will you take a minute and introduce yourself and give the audience a little background on your journey to CIO here at Williamson Health?
Sure. I'm Jeff Goad. I've spent my 39-year career in health IT. It obviously wasn't planned out that way, but that's how it's ended up. I started with a financial software vendor in Atlanta, moved to another vendor that developed executive information systems before Windows 95 was released. Then I was a consultant for 20 years with a firm that helped community not-for-profit hospitals like this one with IT management, planning, and governance. And then 8 years ago, I came here. Title changed to CIO about a year ago, and still working through that. It's fun, challenging, stressful, but especially rewarding, seeing the impact the IT team here has on the vital community asset that a hospital is.
You mentioned vital community asset. I just saw the ribbon cutting with Daryl Waltrip and Luke Bryan, and it looked like a really awesome event. And one of the things that we've talked about along this process is the patient experience, and the patient experience is becoming increasingly important in healthcare because patients have more options than they ever did before. And one of the systems I know you mentioned a few minutes ago has come online here recently is that you're implementing in the new tower expansion is a patient entertainment engagement system. Mm-hmm. And in addition to doing that in the new tower, we're also going to roll that out across your existing facility. So, when you're implementing new systems like this, obviously there are pros and cons that go along with mm-hmm. that. Let's touch on the pros first. During the system demonstrations, you and I saw a lot of different features and a lot of technology that's out there that not only improves the patient experience, but also the caregiver experience as well. What are some of the benefits and features that led Williamson Health to move forward with implementing a patient engagement solution?
Well, I think first of all, in this area, as you mentioned, people do have a choice. Expectations are high, and part of meeting that in 2023 means appropriate use of technology. And the new patient rooms we've opened have 55-inch TVs, which are obviously a nice thing, but people really expect that now. So, right. But the new system we have, it's got digital TV, it's got an entertainment library, allows family to cast from a personal phone to the TV, which is all neat. But it's also got information about their stay displayed there in real time, like their attending physician and nurse every shift, the diet that they're on, their plan for the day, any orders that are in for radiology or anything like that. And so they can be involved in their care. The other neat thing that we've gone live with in the first phase is patient education. We can order videos specifically to the patient room. And then they watch them when it's convenient for them, not because we walked in with a stack of papers.
Right.
They watch it when it's convenient for them. Our EMR records that they watched it, so we're documenting the care and the education that they received. And that saves time for our staff and makes it more convenient for the patient as well. They're more likely to retain what they watch.
Right.
We hope to extend that to things like meal orders. We're not doing that yet, but just a lot of different options and potential that we're looking forward to.
Yeah, there's a lot of potential there with a system like that. And, obviously let's talk about the cons, because when you roll out something like this that's mm-hmm. new, there's struggles that are there. And, tell me something that you would like another CIO or another facility, something that they should look out for or plan for when rolling out a system like this?
Yes. Well, I think our peer organizations know these things come with a lot of moving parts, and you've got the technical challenges. We met those. Went with what's usually a 12-week timeline. We were done in about 8 weeks. I think the biggest challenge for us that I would advise people to watch for is to start soon enough with the planning, going all the way back to your selection process, vetting your references, allow time for if there's a shift in who favors what vendor that you can go back and revisit and have time to do that. Just putting the contract together, the total contract for this, including the TVs, was $750,000. And so everyone kind of paused when they looked at that, but I think we're seeing after it going live the first week, it's going to have a huge impact. But you and I started this process 5-6 months ago, and we really could have benefited from an extra 2 to 3 months on the front end
Right.
for the planning. So I would emphasize the planning. But bottom line is we made it. This is a great week and a great outcome. I think it's going to generate a lot of interest. Yeah.
Yeah, and I know one of the things that drives that is technology systems interoperability. You have to get the integrations in place so these systems can talk to each other. And that's one of the most important things that we've discussed, during this process was, trying to eliminate or greatly reduce that fragmented siloed approach. And, in doing that, manufacturers have to adopt open standards, to ensure that different systems can communicate with each other seamlessly. And this sometimes, will lead or require collaboration between competing entities or vendors to establish those common standards and protocols. How important is technology systems interoperability for your department?
Well, it's important. We have a mixed track record of implementing it, but it's important. Our partners are trying, our providers are trying to adapt technologies as we put them out there. One thing in this area where you've got multiple providers, a patient can present at any number of locations that may or may not be part of your network. And so we'd like that interoperability to be there, that the patient could see, the provider could see what visits the patient has had at other facilities, go to the common, it's more common to track the medications now. The payers and the drug companies are doing that. So it's easier to get that view. So that's an example where it's working well. Inside the hospital, we've tried some things like medication safety, the integration there with just the EMR, the scanning technology, patient safety. I mean, that's an area where it's helpful, but the integration with outside providers, admittedly, we're still working on that, but I think it shows promise, and you receive better care if the provider has that full view.
Right. And that brings up a good point. So, when everything's talking good and smoothly, everything's, running smooth. What does the lack of interoperability between those systems, how does that directly affect your day-to-day operations?
Well, I think we still have some workflow issues where information that might already be in a certain place, whether it's our EMR or somewhere else, ends up getting printed and scanned into our legal records. So things like that are a duplicate. It's like you're recording information 2 and 3 times. And so you've got some issues there. One issue we ran into, there's a kind of a sharing tool called Commonwealth. But the problem is if we connect to that network and pull continuum of care data that way, it counts against our statistics for CMS differently.
Okay.
And if we actually, if we ingest those records, they count in what's called our denominator. Well, that requires our providers to do a lot more work on their end to reconcile the records, and we get credit for meeting the stat. Walked through all that, and as a result, some of those features we're not using, just to not put an undue burden on the providers to do all that documentation. So I guess regulatory would be one of the hurdles that causes us some issues there.
Okay. Yeah, and that kind of leads into the next topic I wanted to bring up was kind of budget constraints. as we've seen multiple projects across the country, as well as, the project here locally is, there are budget constraints. And as we continue to deal with supply chain and lead time issues, we're also seeing unprecedented pricing escalation. So a budget that you set 2 years ago when the project was getting funded is no longer valid. The challenge is you still need all that same equipment, and if not more, to achieve, the same end result. And, to manage your IT budgets effectively, how are you guys prioritizing and rearranging your investments, to make sure you have the most significant impact?
Well, the process here occurs almost in real time. I mean, we rely a lot on our IT steering and executive team, which is a lot of overlap there, to set priorities. So we keep a running list of our projects and anticipated costs and try to make informed choices together. The focus is on new functionality, automation for frontline functions whenever possible. But we've also, fortunately, the governance team has developed a good high-level understanding that it takes a lot of infrastructure that you'll never see to keep it all running. And so we always have those big ticket items mixed in with the application needs. What you're saying is right about the escalation. I mean, my budget since I've been here usually hovered between 6.8, 7.3 million operating a year. And next year, I tried to trim everywhere I could, and I ended up at 8.4 million for next fiscal year. So it's across the board.
So that brings up another point. Have you guys looked at moving your equipment purchases to more of an ongoing recurring OpEx model versus the upfront CapEx expenditures?
Yes, and we, of course, a lot of that's driven by our application vendors. If they offer a subscription or offer a cloud service, if we can make it make sense financially, we'll sign up for that. So, for example, we've done that with our speech recognition. That's the biggest one. There may be a couple of other areas, maybe a couple of financial vendors. They switched to cloud, and we did that. We keep an eye on things like our EMR and our PACs, which are very data intensive, very infrastructure intensive. And so far, the comparisons there, we still come out ahead spending the capital intermittently and keeping up that environment, as opposed to some very large monthly cost were we to go to the cloud. So we're keeping an eye on it. We're trying to be practical about it.
Understood. You mentioned cloud computing. One of the roles of your group is to, effectively manage cloud-based solutions, and to ensure that the data is secure, all while, you mentioned compliance, maintaining compliance with regulatory requirements. And, over the past few years, we've really seen a shift to cloud-based solutions versus having on-site equipment and servers. And, as it relates to the cloud, what changes are you and your team making to reduce the amount of equipment needed on site?
Well, we're managing that internally right now. Just again, trying to make practical decisions. And a good case study for us that's in front of us is replacing our diagnostic imaging, our PACs for radiology and cardiology. The data from those systems, that makes up over 60% of all the data that we store.
Oh, wow.
And so it's obviously a key decision point for us whether we keep that on the premises or move it to the cloud. It's going to have huge implications going forward. And we're really right in the middle of that evaluation and trying to decide what makes sense. Because, when I got here, I thought, well, I really hope we don't have a data center in 5 years, but obviously we missed that mark.
Right.
And now I don't know if I said it today, but I would think the same thing. I would like for us to not have much of a footprint 5 years from now, but we'll see how it works out.
Yeah. And that's, that it brings up another topic of, digital transformation. That phrase is, in my opinion, it's sometimes misused and often overused, mainly by, manufacturers or companies that are just trying to sell more features, or sell more boxes of stuff. And the definition of digital transformation will mean one thing to one group and mean something completely different to somebody else. And as a group, Aptitude, we've done a lot of research on this topic, and My 50,000 foot definition is digital transformation is the process of integrating digital technologies to create new or modify existing processes to meet the ever-changing business and market needs. And I think that's pretty black and white, if you look at it from our standpoint. And, at the end of the day in healthcare, it ultimately enhances the patient and caregiver experience.
Exactly.
And as it relates to digital transformation, what have you guys seen over the past few years that have directly impacted positively or negatively,
Right.
The healthcare IT environment?
Well, first of all, you're absolutely right. The term it's overused a lot in both media and the sales processes, but we try to look past that. And we have seen some benefits here. Obviously, when the pandemic started, we were able to do things that we would not have thought we could do, like roll out virtual visits in a 2-week time frame. Then we didn't like that solution. We rolled out another one in a 2-week time frame. So that allowed the patients to get their the vital care in a safe environment, and obviously direct benefit to the patient. In addition to technologies like that, things of convenience for the patient where they can, manage their record, look at their refills, look at their schedule a new appointment. That's part of the patient experience as well. Can they do these functions when it's convenient for them to do them in an easy fashion, such as a phone? And I know that my provider, they provide this app, and I use it in addition to the apps that we provide here. And it really does make for a better experience for getting the care you need.
Yeah, you mentioned too, the evolution in software design and patient-friendly and easy to use. Brings up the nice new shiny phrase of artificial intelligence, when it comes to AI, you're either really on board with it, fully embracing it, or you're not there yet, or you're totally against it and not ready to introduce it into your daily environment. And we see it all across the board. We see the big proponents of it, and, we see people using it. And, how do you think you're going to be able to effectively integrate AI into, your clinical processes and workflow here at Williamson?
Well, we're already seeing some examples. We've contracted with a local firm for kind of an overlay to our EMR. That's to assist providers with clinical decisions, and it gives them clinical data, cost data for effective treatment. And of course, those things have been around in some form or fashion for 20 years with kind of a mixed record of adoption. But I think the intelligence out there now, the data sources, the real-time processing, makes it more likely these will gain traction.
Right.
We're looking at other tools now that help us look at, say, our traffic patterns in our ER, help us make staffing adjustments, look at schedule utilization in the OR, and help us manage those blocks and make adjustments among providers. Our innovation officer, Dr. Benson, is helping us look at several of those tools right now, and we're probably going to adapt quickly. I think that's kind of we just need to be open-minded and adapt what we practically can.
Right.
It's here whether we're open to it or not. And
Sure.
So I think we're trying to explore all the angles and look at solutions that have a practical impact on our operation here.
And that, obviously that's going to bring more traffic to your network, and with telehealth, being out there and being so prevalent. If COVID taught us anything, it taught us not only the importance of telehealth solutions, but, also the need for them. And, as telehealth continues to be, become more prevalent in our industry, what plans do you guys have in place to handle network traffic, to effectively deploy telehealth, and I'm just not talking about doctor visits. Live streaming videos showing x-rays, charts, and maybe even using it to broadcast live operations or medical procedures for educational purposes. What are you guys looking at doing there?
Well, I'm sure we could use a current assessment of what we have, but over time the backplane on the campus is pretty solid, and we've also partnered with our local carrier to develop a pretty robust wide area network. And we have 2 nodes that are at 10 gigabits, one for our disaster recovery site, one for outpatient imaging center. And then our clinics connect anywhere ranging from 250 meg to a gig. And so we feel like we're ready at one level for that, but definitely we're going to have to keep our eye on it to keep up over time.
Yeah, and obviously a concern there is going to be security.
Yes.
And with everything we've talked about today leads us to that final topic of cybersecurity. You and your team, have to consistently monitor and, implement robust security strategies that, include regular assessments and employee training and, the use of other advanced security tools, and also to have that preemptive strike measures, against, intrusion threats. So how do you currently handle cybersecurity? And I realize that is a very broad question.
Yeah.
But, how do you guys handle it? And is there maybe a story you could talk about where, you've seen something work, or maybe a story about a situation where a plan didn't work?
Sure.
And, what was done to resolve those issues?
Sure. Well, we're kind of handling the topic by committee within our IT department, meaning there's not a direct analyst assigned. And I wouldn't recommend that to peer organizations. There needs to be a person assigned to cybersecurity, but we're working on that. We have a good senior engineering team. We've got a complement of maybe 12 or 13 solutions that have kind of layered in over time. It's not perfect, but they work. I think the thing that's really kept us in the game is having two local partners who are highly effective. One of them has managed our IPS IDS for 10 years, alerts and follow-up 24/7. They're great communication. That same firm we've contracted with for a new EDR, endpoint detection, to help us monitor that. And in the few weeks we've had it rolled out, we've already got so much more visibility and able to address, remediate some issues. Our other partner handles a lot of our regulatory stuff. As a hospital, as a provider, we have to do a HIPAA security risk analysis, conduct a review every year. And that partner also has a hosted SIM that our EDR integrates into that, helps us with our vulnerability threat management. They scan the network monthly, get all the Windows updates, all the areas where we're behind. And then they do our network penetration testing as well. So we've got those two partners. Again, both of them cost, the way I stage it to get them, that each one costs less than an FTE. If you had the FTE, there's no way they could cover that much ground.
Sure.
And so we try to use those dollars the right way. And, the most recent episode we had really was over Memorial Day weekend. We had a credential harvesting that someone tripped up on, an alleged DocuSign that really wasn't. Well, then we ended up having spam email from our own accounts into the rest. And, within just a few hours, in a few minutes, we had narrowed down the 6 accounts that had been compromised, got those people shut down, took a PC offline that we were concerned about, and were able to cover a lot of ground due to this new EDR and this new partner we had working on the issue. And then remediation throughout the rest of the weekend, we tightened some holes that were there. I think one of the more impactful stories, and it's just kind of sharing how leadership views IT and what their responsibilities are. About 4 years ago, there was a major health system in the region that were hit by ransomware, highly publicized. Everybody knew about it. Yep. And the initial reports, which a lot of the reports they issued, it just showed how glaringly unprepared they were. They were turning away visits to the clinic, went on diversion at the hospital, except for the most serious emergent cases. And so I asked to meet with the executive team, and I put together a list real quick from our engineers, and about 20 things, just things of convenience or loopholes we had here we needed to close. I came up here, presented that to the team, and paused, just kind of said, okay, how would you like us to proceed with this? And I looked around the table. No one said a word. They just all looked me. They looked me straight in the eye like, you've already done this, right?
Right.
And all I said was very well. And I left the room. We had it all done within a couple of hours. And of course we had a lot of complaints, but we also had good backup, good support from that governance team to pull us through that, and going through some similar processes right now after our Memorial Day event. But I say it's an event. It was actually a non-event because we caught it so
Because you caught it.
quickly. It's
Right.
an incident, but we addressed it. So just there's a lot of interesting things, but those are the two that come to mind.
Well, Jeff, again, I appreciate your time. We will certainly look forward to doing this again. Congratulations on this beautiful new facility that you've got opened up, and look forward to talking to you again soon. And again, thank you. Thank you for your time.
Thank you, John.